Welcome to our first ever Fielding Talks here at UCLA. My name is Firuz Kabir. My pronouns are she, her, hers, and I'm a second-year MPH student and incoming PhD student in the Department of Health Policy and Management at the Fielding School of Public Health.
Hi everyone, my name is Alyssa Arbelante, second-year MPH student in the Community Health Sciences Department, pronouns she, her, hers, and we are this year's National Public Health Week co-chairs from the Students of Color for Public Health.
All right. We are so happy to have you all in person, and for those of you joining us via live stream, welcome. We will have a Q&A session towards the end of this event, at which point we will take questions from those in the room as well as from those submitting questions from the chat box.
All right, please find the digital Fielding Talks program by scanning the QR code on the screen that should be popping out right now. All right, so before we move forward with what we have planned for today, on behalf of Students of Color for Public Health and UCLA, we acknowledge the Gabrielino Tongva peoples as the traditional land caretakers of Toangar, Los Angeles Basin, Southern Channel Islands. As a land-grant institution, we pay our respects to the ancestors, elders, and our relatives' relations, past, present, and emerging.
All right, so as mentioned earlier, this is our inaugural Fielding Talks, and this event is one of many that have taken place during National Public Health Week, which, if you all didn't know, happened this week, and sadly it's also coming to an end. But a little bit about National Public Health Week. It is a 25-year-old initiative by the American Public Health Association that takes place across the country. And NPHW is a way for us to promote appreciation of public health and highlight issues that are critical for improving community and population health.
This deeply connects with the idea behind Fielding Talks, which was largely driven by the purpose of providing students a platform to put public health issues at the forefront and to provide the UCLA community, that students, faculty, and staff, the opportunity to gain innovative ideas from students on how they can contribute in addressing these issues.
So overall, the goal of Fielding Talks is to educate our campus population regarding public health problems and actionable solutions, to raise awareness of campus-wide public health advocacy, and ultimately empower our student speakers today to continue their work in tackling health and medical issues faced by disproportionately affected communities in our society. We see Fielding Talks as a way to actively engage our campus community and inspire future student-led public health initiatives that will lead to public action at both the individual and community levels.
In public health, we believe that knowledge is power, and it should be shared and be made accessible to all and to those who seek it. And so we hope that you will walk away or walk out of this event, or for those of you live streaming, walk away from your screens feeling empowered with this newfound knowledge on how to actively contribute as concerned citizens in addressing these public health issues through effective and realistic solutions that our lovely presenters will be talking to you all about today.
All right, so Alyssa's point about making knowledge more accessible is really the foundation of this year's Fielding Talks, which is centered on improving access as a means for closing the health equity gap. As many of us know, not everyone has equal access to the information and health services they need to truly thrive. Disproportionately affected populations, including racial and ethnic minorities and people of color in the US and around the world, experience serious health and social disparities as a result of unequal access. For us at Students of Color for Public Health, or SCPH, this is a very personal and critical area for discussion. And this drove us to create this collaborative space today to hear directly from our peers on how to improve access and take a more equitable approach to closing gaps in health and medical care. Now I'll pass it back to Alyssa, who will introduce our lead advisor for NPHW. And from there, we will hear from our wonderful speakers and then move on to a Q&A session.
Thank you. So Dr. Julianne Jose Chen is the Assistant Dean for Student Services at the UCLA FIelding School of Public Health. She will be giving us a few words regarding National Public Health Week and the role of the Office for Student Services at FSPH in promoting student development on campus. She has been an incredible advisor and has played a vital role in making National Public Health Week happen here at UCLA this year. Firuz and I are just so lucky to be able to work with you and receive guidance and help us grow professionally and becoming leaders along the way. We really can't thank you enough for the amount of support you have given us and your patience with the countless emails that you've received from us. So yeah, please help me welcome Dr. Julianne Jose Chen.
Thank you, Alyssa and Firuz, and I'm gonna miss those emails after this week, but you can always email me about anything. Welcome everyone to the inaugural FieldingTalks event. As Alyssa mentioned, my name is Julianne Jose Chen. My pronouns are she, her, hers, and I am the Assistant Dean for Student Services in the Office of Student Services at the Fielding School of Public Health. We hope you all have enjoyed the events and activities thus far during National Public Health Week, which were put on by the Students of Color for Public Health as well as our National Public Health Week partners. I'd like to take a moment to thank our partners, the Coalition for Queer Public Health, Community Health Sciences Student Association, FSPH Student Ambassadors, GlobeMed at UCLA, Health Policy and Management Student Association, Maternal and Child Health Student Interest Group, Mobile Clinic Project at UCLA, UCLA Public Health Student Association, Reproductive Health Interest Group, Scope Patient Health Advocates, UCLA CPR and First Aid, and UCLA Center for Global and Immigrant Health, as well as our sponsors, UCLA Fielding School of Public Health, the FSPH Office of Student Services, and the Office of Equity and Diversity and Inclusion at Fielding, and the Public Health Student Association. Special thank you goes out to Students of Color for Public Health who have organized this week's event, and a special shout out to the co-chairs on National Public Health Week, Firuz Kabir and Alyssa Arbolante. Please help me in giving them a warm round of applause. This year's theme for National Public Health Week is Public Health is Where You Are, and today's event is, which is a culminating event for the National Public Health Week, will be focusing on accessibility, closing the health equity gap. For myself, in my role in the Office of Student Services, the way I feel that I can help addressing equity overall is to work with my colleagues on facilitating holistic student development, which is the wellness of the whole student. So not just the parts of you that make you a student, like the classes, the maintaining your GPA part, the graduating part, but also the parts of you that are not seen in the classroom. What makes you you? Your family, your friends, hobbies, interests, most importantly, your engagement and involvement with the community. I feel like one of the major things I can help with is to amplify and lift up the student voice. So I was beyond thrilled when Alyssa and Firuz had brought up this idea for FieldingTalks and the theme. Similarly, what I feel is our guiding values in the Office of Student Services are what this week and Fielding is all about: caring for the community, all parts of our community, and amplifying the voices that often go unheard. So thank you again for attending today's FieldingTalks, either in person or virtually, and I want to hand it back to Firuz and Alyssa, who will be introducing the first speaker.
Thank you so much, Julian. All right, so now we will transition to our student presenters who will be giving the actual FieldingTalks for this afternoon. And just a quick note, as we mentioned earlier, there will be a Q&A session after these 4 presentations. So please save all of your questions till the end of all of the presentations, at which point please raise your hand or submit your questions in the chat box if you're joining us on the live stream. So now to kick off this event, I will introduce our first FieldingTalks student presenter for today, Jacqueline Beltran. Jacqueline is a Los Angeles native who attended Pennsylvania State University, where she was a McNair Fellow and obtained a Bachelor of Science in Kinesiology. Aside from being a McNair Scholar recipient in her undergraduate career, Jacqueline also studied abroad at Oxford and UCL, where she was introduced to healthcare systems on a global scale, with a specific focus on public health. This led to her interest now in public health, and it is one of the reasons Jacqueline is now an MPH candidate at UCLA. While attending UCLA, Jacqueline also works with the Department of Public Health in Los Angeles County on procurement policies, with UCLA professor Dr. Mei Wang on food security, and with Dr. Chelsea Shover on homelessness initiatives. Some of Jacqueline's research interests include food law, food insecurity, obesity, and homelessness at the individual/legal level. Aside from school, she enjoys extreme sports such as white water rafting and riding ATVs. In her limited leisure time, she hikes and travels outside the country quite often. Prior to the pandemic, she prioritized taking one vacation per year outside of the US to acquaint herself with other cultures and their ways of living. Jacqueline's fielding talk for today is titled, "What I Have Learned from Providing Vaccines to Those Unhoused During COVID-19." So without further ado, please join me in giving a warm welcome to Jacqueline.
Thanks. So I think I'll be using this one because you guys can hear me, right? Okay, great. Just want to move this aside. So hello, thank you for coming to my talk about what I learned of vaccinating the unhoused population during COVID-19. Before I begin, I'm sorry, are the slides? I can't see them. Oh, there we go, sorry. Before I actually begin, I'd like to set up the agenda. I think it's a good way for us to kind of know where the conversation will go and lead. So first I'll start by sharing a little bit about me, my history, my interests, how they all sparked and kind of intersect now, the impacts of COVID-19, specifically setting the foundation of some statistics so that we're all on the same page. And then personally, my experience being told through storytelling of what I gathered from the people that I encountered during this work over the summer. And I'll finish off with giving my pitch for what UCLA community can do for this vulnerable population. So aside from being a scholar, I want to bring it back a little bit to my origins. So I'm actually a product of two immigrant parents who immigrated here, one in her late teens and my father in his early 20s. And my father, actually, to go a little bit further back, was raised by a widowed mother who had to raise 4 children by herself. And she taught her children and ingrained in them that when you're in a position to help others, you should do so. And she is a human who led by example. In her village, when people could not afford to pay the meals from her food stand, she would give them out for free. And my father grew up with this value and brought it up in our household as well. And I think that's why I've been drawn into helping others. And it's manifested in many ways. In elementary school, I was very vocal and tried to be very fair with a lot of my peers. So in 2nd grade, my teachers took notice to that and suggested that I be placed in a program to train me as a peer mediator, which I did from 2nd grade up until middle school. And basically what that means is just de-escalating issues among our peers and helping them kind of find like a common ground. Following that in high school, I volunteered with the Red Cross. In undergrad, I did Habitat for Humanity. I did building homes here in the US in different states, but also I did it abroad. I did it in Poland and Canada. And I am a founding member of a diversity and inclusion organization housed within the Healthcare College at Penn State University. So we've established this overarching theme in my life of the need to help others. But I think that's the main reason why healthcare is why they intersect, right? Healthcare, you help others. There's this overarching theme that has been lingering in my life. But I believe that it's also in my bloodline. I come from a family of 2 aunts that are in the healthcare system. One is a nurse manager and another one creates healthcare policy within her country. My 2 sisters are both in the nursing world. And me, myself, we're all very deeply passionate about healthcare, correct, and our efforts. But for my journey coming into public health, it actually wasn't very linear. I began undergrad thinking that I was going to go to physician assistant school, but it wasn't just enough to be a physician assistant. I wanted to be a well-rounded physician assistant. And for me at the time, that meant being someone that was aware of healthcare systems in other countries, analyzing what other countries were doing and what was successful there, and then hopefully implementing those skills that I had learned from other countries in our healthcare system here in the US. So as an undergrad, I began to research what opportunities there were, and that's kind of what brought me into UCL in my photo over here with Big Ben. There was an interesting program that combined University College of London and Oxford in analyzing the healthcare systems of the US, UK, and Jamaica. And this is my introduction into public health, and I developed a great passion and love for combating non-communicable diseases. But I'd like to bring it back because this is me getting ahead of myself. But we've established this overarching theme of helping others and aiding others. But something that I've noticed as I've gotten older is that while some of us were brought up with this ideal of helping others, others have grown up to be very individualistic. And I think that the pandemic has taught us that that's really unrealistic given the societies that we live in. Something that happened in another country, such as COVID-19, came here to impact us. So if that doesn't put it lucid enough that we impact one another, I'm not really sure what will. This pandemic also exacerbated many issues within our society that were already intersecting, but even more clearly highlighted how some individuals were disproportionately affected by the pandemic. Really, it exacerbated issues some of us knew about and forced others to acknowledge. So let's start by setting the foundation. I'm going to share some statistics with you. So food insecurity in the US has been increasing, with NYU finding that prior to the pandemic, 11% of American households were food insecure. And during that pandemic, that number increased to 15%, with 18% of those households having children in them. This intersects with racial ties and housing. An estimated 24% of the African American community experienced food insecurity in 2020. As people experiencing homelessness, we know that despite African Americans only making up 13% of the population, they account for 39% of the individuals experiencing homelessness, and over 50% of those that have families that are experiencing homelessness with children. And then let's put a little bit of perspective onto what happened with jobs during the pandemic. Pew Research found that 15% of adults lost their job during the pandemic. And we also know that 15% of chronic homelessness increased from 2019 to 2020. So this is suggesting that there is a rising needs and vulnerabilities among the homeless population. We know that there are varying resources in communities. I saw that growing up in the community that I was raised in. I had the opportunity to study in a different district, in a different community, and I saw the overabundance of resources being provided to significantly less students. And we also know from research that socioeconomic status plays a big factor in what resources you have access to that we know are correlated with healthier outcomes. So hopefully the foundation has been set. So how do we, as healthcare providers, try to meet the needs of the most vulnerable populations, especially during a pandemic? So for me, it started with volunteering with Charles Drew University. So if you're not familiar with that institution, it's a predominantly healthcare institution located in South Los Angeles. And in March 2020, I knew I had to do something, that I couldn't just sit at home and stay on the sidelines. So luckily, Charles Drew University at the time was a majority student-run site, and we were testing, let me backtrack. They were searching for volunteers that were passionate about healthcare. Me and a bunch of other students who were either in their master's degree or in their doctoral degree related to healthcare. And I spent all spring and summer volunteering with them. And specifically, we were doing in March 2020, we were trying to get back to people their results, whether they were positive or negative. And this is really where my work begins with all of this. But these people needed their results immediately and effectively because the majority of the population I was interacting with, did not have the luxury to work from home. This experience allowed me to gain the skills to obtain my summer internship. So fast forward, I accept my offer to FSPH, the Fielding School of Public Health at UCLA, and I began my Master's of Public Health, and soon enough it's time for my practicum. So here's an image of me doing the work that I'll be describing more in depth in a little bit, but you can kind of see the level of interaction that this required, and I hope that you can see that from the various statistics that I'll share with you about the research. So at the time, Dr. Shover needed someone that was bilingual and was interested in vaccine access. Well, I fit both of those criteria. And this is where I really begin to see the parallels and the issues start to intersect of food access, housing access, and access to care. And I began by working on this effort. And it started by having graduate students such as myself go out with the population and build rapport, start with a conversation, and then tell them of the resources that we were providing during the day and the vaccine. So post working out all the kinks as graduate students, we then build capacity among different government institutions and specifically among their staff so that they could take it on. Because it was never meant for UCLA to continue the work. It was meant to build the capacity of their staff within these different healthcare organizations. And then following that, we got IRB approval to actually recruit what we call or termed peer ambassadors to help us do outreach in their own community to those unhoused and who wanted to be exposed to healthcare resources, but also the vaccine. And specifically, this was actually really extremely successful, and I want to put that into perspective. We got some media attention from the LA Times, and you can see here the title specifically, but that this might be the way to get people vaccinated that live in these conditions. And I'll show you quantitatively what was so significant about it to getting people vaccinated, but aside from the quantitative data, here you can see the attribution of a peer ambassador in blue to those who got vaccinated during that time frame. But I'm not going to belabor this because this will be in manuscripts that you can look up. We also did some qualitative data from those who engage with peer ambassadors, so the staff in UCLA folks, and personal experiences that the staff had with engaging with this population, and also anything that they could paraphrase to directly quote for our qualitative. And what we found was that they stated that we let them be themselves, accepting the values of peer ambassadors, and this led to approaches of them really being the ones who took the lead in how we were going to approach their community and saying that we were providing these resources. That we established genuine trust and equitable working relationships with community health workers and peer ambassadors. So community health workers are the staff members that we actually built capacity relating to this project. And that there were trade-offs in integrating peer ambassadors into the existing community health workflow. There was also mention of ethics of exploiting the invaluable trust that peer ambassadors had already with their own community. But we ultimately concluded that community health workers were in a unique position to empower those that are unhoused, to take the lead in providing and sharing the resources and vaccines for their community, but also advocating for long-term employment and housing needs. Now I'd like to share some of my personal experience of working and recruiting with other peer ambassadors. I learned that not all of us have the same support system, and while I was aware of it before, I guess the first raw hand experience of seeing it daily, that there are humans out there that are missing basic needs, put it very clear to me. It also showed me that many Americans who live paycheck to paycheck could easily find themselves in this position. If they don't have a support system or a plan that disrupted their routine, such as COVID-19, they could easily be in the same place of the people that I was interacting with. And specifically, I remember a story of a peer ambassador who moved to California with no family here or much of a family left behind, and she had a job and she was thriving. Unfortunately, she lost her job and she moved into her car. And she said, until she was back on her feet. Well, that got difficult since she didn't have an address to put down for jobs on the applications that she needed to submit. And then a week turned into a month into a year, and a year into a decade. Sometimes life happens. And for whatever reason, we're not all fortunate enough to have someone to pick us up or lend a hand. And from similar stories of unfortunate events that led to barriers to access to resources, I learned from this project that when people are given the opportunity to help themselves and their community, they are willing to do the work. That despite being in circumstances that are deemed extremely difficult, they are some of the most resilient and optimistic people I have encountered in my life. And finally, I learned that there are gaps and that we can do more. At the individual level, we can begin to explore different organizations that are meeting the needs of this population, and that we as a UCLA community, so let me go to the next one, so that we as a UCLA community with a huge support system, with an overabundance of resources and brilliant researchers, can begin to create innovative and leading programs to mitigate negative healthcare outcomes among this population. Specifically, we can be leading in efforts in one, if not the most, prevalent public health issue this nation is facing, and create opportunities for the next generation to face with tangible research agendas. And I'd like to leave us with directly quoting a statement made in 2018 by the California Policy Lab relating to homelessness initiatives, that UCLA must play a role in this effort, and that begins with learning more about the crisis and the response, and laying out a research agenda. Thank you.
Hello. Okay. All right. Thank you so much, Jacqueline, for that wonderful talk. I will now take the honor of introducing our next presenter, Lupac. Dome is an MPH candidate in the Department of Community Health Sciences with certificates in the maternal and child health and global health, and a specialization in health promotion and health education. He immigrated to Carson, California from the Philippines in 2004. Dome received his Bachelor of Arts in Public Health and Social Welfare from UC Berkeley in 2017. His passion for public health stems from addressing the health inequities that disproportionately affect immigrant children and families, particularly nutrition and physical activity promotion and chronic disease prevention. For hobbies, Dome enjoys going on hikes, traveling, cooking, dancing, staying physically active, and learning more about personal finance. His fielding talk today is titled, "The State of Food Insecurity Among Us." Let's give a round of applause for my dearest friend, Dome Lupac.
Thank you. Can you all hear me? Good. Thank you all. Hi, everyone. My name One second. There you go. Awesome. Sorry for that technical difficulty. Hi, everyone. My name is Dome Lupac. My pronouns are he, him, his. And today, I would like to talk about something that we all need and love: food. Food is something we need to survive, grow, and thrive. Food nourishes us and gives us the energy we need to tackle our days. Food connects us to each other, as a simple meal can spark conversations and bring people together. Food is also a symbol of the love and care we have for our family and friends and community. Food also connects us and allows us to celebrate our culture. For example, coming back home from college, I always look forward to eating my mom's version of my favorite Filipino dishes. Then, whenever I'm lonely in college or stressed because of schoolwork, attempting to cook my mom's recipes somehow made me feel much better and connected back home in Carson. As you can see, food is an important part of life, but unfortunately, many people around the world do not have access to adequate nutritious food and are therefore food insecure, including my family and I. Before I explain how my family and I experience food insecurity, let me first define what it is. The USDA defines food insecurity as lack of consistent access to enough food for an active and healthy life. Additionally, food insecurity is closely related to poverty. Not all people living below the poverty line experience food insecurity, and people living above the poverty line can experience food insecurity. Growing up in both the Philippines and the United States, I have personally experienced and witnessed the ramifications of being food insecure in different ways. For the first 10 years of my life, I was raised in Manila, Philippines, where my father worked as an electrical engineer and my mother a school nurse. Most of the time, we had food on the table. However, sometimes money would be tight so that we did not have adequate food to eat. There was a few times where the only thing we had to eat was a pack of Lucky Me noodles, shown in the slide, with 2 eggs shared among 5 people, or soy sauce with rice for dinner because we didn't have enough money to cook a meat dish. When we moved to the United States, my parents were not licensed to practice their professions back in the Philippines. Thus, they balanced multiple low-wage jobs to make ends meet. Living paycheck to paycheck, we experienced food insecurity more times in the US compared to the Philippines. However, a difference I've noticed between the Philippines and the United States is that we benefited from different food and nutrition assistance programs that help low-income individuals and families like mine to combat food insecurity, such as SNAP, or the Supplemental Nutrition Assistance Program, and the free and reduced breakfast and lunch programs I received at school. Additionally, in Carson, we participated in various food distribution programs that provided my family with food items like canned goods and bread. However, as I grew older, I started to get embarrassed with the stigma associated with public assistance. I also recognized that despite receiving specific food items, we would not end up eating it because we were unfamiliar with it and how to prepare it. Since the beginning of my undergraduate career, I have been part of an organization that recognizes the challenges of recruiting and retaining Filipino American students into higher education. Given my low-income background, I immediately felt out of place in an institution that was not built for students like me. Apart from struggling academically, I experienced financial difficulties in buying food. I remember I would force myself not to eat breakfast so that I can afford lunch and dinner, and get lunch but split it between lunch and dinner to save money. Simultaneously, in my junior year, I started volunteering at the Mabuhay Health Center, which is a clinic that provides free health resources and services to the unhoused and immigrant populations in the South Del Market District in San Francisco. As I further realized the impact food insecurity has on others, my volunteer positions in this organization for 5 years has allowed me to act on these issues, even in a small way, to ensure that people have access to nutritious foods. Through this position, we were able to partner with a local food bank to provide produce to clinic patients every month. I would also cook monthly meals using healthier alternatives to many Filipino dishes, and provided recipe cards so that patients are able to replicate these recipes at home. At the Fielding School of Public Health, where I am studying community health sciences, I was able to further deepen my understanding and passion for food access. Recognizing the many different social determinants that lead to food insecurity, I started to ask the questions like, how can we as individuals and as a community start working towards food security? What does food security even mean? And how do we decrease the stigma and provide respect and dignity to those in need of food assistance? One particular class I took was the social determinants of nutrition. For those of you watching, it's HS224 with Dr. May Wang. And so in this class, as shown in the slide, we were asked to create a concept map to demonstrate and depict how a physical and social aspect of one's background influence food security, as well as the consumption of unhealthy and healthy foods. In talking about my passions for food access and my desire for opportunities that will allow me to be more involved in this topic, Dr. Wang was also the person who introduced me to one of our research projects who previously Jacqueline Beltran is also a part of. This is a project that is in collaboration with the UCLA Community Programs Office, or CPO, to explore the extent to which UCLA students and staff experience food insecurity before and during the pandemic. Before I move forward, I would like to preface that staff includes faculty. So moving forward, I'm going to say staff, but it also includes faculty. To provide some context, literature review shows that food insecurity is associated with poor health and learning. A 2015 University California system-wide survey showed that over 45% of undergraduate students and 25% of graduate students had experienced food insecurity. However, little to no information are found regarding on how food insecurity impacts staff members. And this is such an important fact to know, because students are starting to question that universities are upholding the values that they promote, such as equity, to not just their students, but to all members of their campus community. Even before the pandemic, the Community Programs Office at UCLA was already supporting members as they participated in various events such as the Food Closet Program and food box giveaways. Thus, in collaboration with Dr. Wang and her research team, both CPO and Dr. Wang and research team came together to comprehend, to support CPO to comprehend and to understand the data they have collected to understand UCLA staff basic needs before and during the pandemic. So in doing so, we all created a survey. We all developed and created a survey that was pre-tested and translated to Spanish and formatted in Google Forms for online administration. In terms of recruitment and sample, we sent out the first invitation to participate on late February 2022 to approximately 620 staff members that applied for food boxes in fall 2020. Additionally, we sent out recruitment flyers as well as distributed them in staff lunch break rooms. Currently, the survey is underway and that reminders are being sent. Today, I'm happy to report that we have about 65 responses, and the next slides where I'm going to be presenting the findings from that survey, preliminary findings from that survey, include those 65 individuals. The questionnaire solicited information about sociodemographics, employment status, and food insecurity was assessed using a 3-item items from the USDA 6-item food security survey module, as well as assessing CalFresh knowledge and enrollment status. So now I'm going to start going into some of the preliminary data. So first, let's start off with demographics. Among those who completed the survey, approximately 50%, specifically 53.30% have a college degree or higher, 31.10% had some college/associate's degree, and approximately 9% had high school diploma. The data in the slides is not shown, but when looking at combined 2019 household income, 33.8% of the participants stated that they made between $25,000 to $49,000 in 2019, and about 25% had a combined income of $50,000 through $69,000 in 2019. So now looking into how we assess food insecurity, So you see, in the next previous slides, we're going to show how we assess food security with statements, and then it's going to be compared to the pre-pandemic and pandemic. And so in our survey, we operationalized pandemic as since March 2020, because March 2020 was the first time where the whole world went on lockdown because it was declared a pandemic. So in the statement, the food we bought did not last, and we did not have enough money to get more. In the pre-pandemic, 44.6% answered sometimes true, 30.8% answered never true, and 21.5% answered often true. When the pandemic hit, or since March 2020, 39.1% answered sometimes true, and 34.4% answered often true. When looking at the question, we could not afford to eat balanced meals, again, pre-pandemic versus pandemic, we see that for the pre-pandemic, 45.3% answered sometimes true, Hello? I wanted to note that, as you can see, like there is, the pandemic did exacerbate some of the experiences of families experiencing food insecurity, because for all of the categories except never true, it went up, and then never true went down. And then the last question of food insecurity that I'm going to be talking about in this survey is we were worried our food would run out before we got money. And so when looking at this, we see in the pre-pandemic, 41.5% answered sometimes true, 30.8% answered never true, and 20.7% answered often true. When the pandemic hit, 43.8% answered sometimes true, while 35.9% answered often true. Again, we see an increase of the people experiencing answering sometimes true and often true, and a decrease of people answering never true. So, in looking at CalFresh enrollment status, and so we looked at it for people, so the first category was households ever enrolled in CalFresh, and then households currently enrolled in CalFresh, we look at the people that responded yes, to these stats. 25.9% ever enrolled, and 21.4% are currently enrolled. In terms of no, we see a big jump, or a big disparity, or like a because more people answered no, and so the numbers are 64.8% in ever enrolled and 64.3% in currently enrolled. And then to further provide context into some of the reasons why, we also had a question on that, when we provided categories, and participants can select what applies to them. And so most of the responses were the reasons why they're not enrolled in CalFresh are they don't think they're eligible, which is one of the highest percentages. They don't want to be part of the governmental program. They don't need help. They never thought about it, and their income was too high. Finally, some of the last stats that I will be presenting is the percentage of households that experience a financial crisis since March 2020, where 58.5%, which is 38 participants, said yes, they've experienced, while 27 participants, which is 41.5%, said no, that they never experienced a financial crisis since March 2020. So when looking at some of the next steps, so I think, while we only have, 65 responses, we want to continue to gain more responses so that we will analyze the data. And then, for those of you, as you all know in public health, right, like we want to utilize quantitative data, but we also want to utilize qualitative data to really get an understanding about some of these issues and provide context as to why this phenomenon is happening. And finally, as a team, we want to disseminate the findings so that hopefully it could influence future step in direction to address this issue. Thinking about my calls to action, so today I laid out with my personal story as well as my experiences and my lived experiences and the experiences I've seen in others, that food insecurity is prevalent and that it impacts many people. Based on what I presented today, I have a couple of calls to action. We must be critical about what food security means. It's not just about providing food, but it's also important that the food that we provide is accessible, available, and acceptable to those in need. It is also important to understand how food insecurity impacts vulnerable communities so that we can come up with solutions that address them at the root causes, and and those solutions continue to center and prioritize the needs of the people and the needs, assets, and capabilities of the people in need. It's also important to understand that the barriers and gaps of people have in accessing these services related to food access, so we can start bridging those gaps and destigmatizing, the stigma against receiving public assistance. Lastly, preliminary findings indicate that universities should prioritize efforts towards addressing food insecurity for both students and staff, as well as this data show that some of the efforts that we should bolster support for organizations that already do this work. Thank you so much for listening to my presentation. And yeah, if you have any questions, please ask me later. Thank you and have a great day.
All right. Thank you so much, Dome. We are about to transition to our intermission break, but before we do, we want to acknowledge that there are some technical issues happening on the live stream, so thank you to folks bringing that to our attention. What we want to do is we want to go ahead and share the slides from our presenters today to those who registered for this event, as well as those who requested. So we will go ahead and put our email in the chat box as well. So at this time, please feel free for those of us in this room to get up and get some light snacks. And for those of you joining on the live stream, please be back around, let's see, it is currently 3:56, so let's say 4:10. So we hope that you will come back then. Thank you so much. start heading back to your seats, we are going to go ahead and resume. All right. So at this point, we are going to continue with the second half of our program. So we have two more amazing student speakers coming up. And I want to now go ahead and introduce our third speaker, Sahar Ashrafzadeh. Sahar is a fourth-year medical student at the David Geffen School of Medicine at UCLA. Having grown up in the rural Midwest and witnessing the limited access to specialized medical care, she is passionate about strengthening and expanding healthcare in rural and underserved populations. Sahar founded the Harvard College Rural Health Association during her undergraduate years to educate students about disparities and to promote health outreach in rural communities. She also spearheaded the Harvard Global Health Institute Student Advisory Council, which successfully enabled collaboration between public health student leaders and Harvard administration on public health advocacy projects. At UCLA, Sahar serves as co-chair of the David Geffen School of Medicine Public Health and Preventative Medicine Interest Group. Her research interests include healthcare access disparities and the utilization of telehealth to extend care to patients who need it most. Sahar's fielding talk for today is titled Rural Mental Health, Challenges and Opportunities. So, without further ado, please join me in welcoming Sahar.
Thank you so much for the introduction. Can you all hear me? Okay, great. So hi, my name is Sahar. I'm looking forward to speaking with you today about rural mental health access, challenges, and opportunities. And like was mentioned, this is a topic that's near and dear to my heart because I grew up in rural Michigan, right along beautiful Lake Michigan, but in a very small town where access to specialty medical care was very limited, and saw how that influenced my family, friends, and neighbors. So just to start, we live in Los Angeles, California, the second largest city in the country. About 80% of the nation's population lives in urban areas. So then why am I focusing on where only 20% of our nation's country resides? I'd like us to do a quick thought experiment. Who comes to mind when you think of a person with a severe mental illness? I think living in a large city, such as LA, we might not think about rural farmers who are dealing with very difficult financial hardship, tough crops, and social isolation, and have much higher rates of depression and suicide. We might not think about the patients who are, in addition to mental illness, dealing with higher rates of diabetes, cardiovascular disease in rural areas, and have to drive 100, 150 miles each way just to seek basic access to medical services. We might also not think about how the opioid epidemic is predominantly impacting rural communities across the country and resulting in many preventable deaths. And additionally, especially here in California, we have our migrant farmers and other members of rural California community who are feeding our country, but themselves face numerous stressors and have very limited access to mental health care. Every year in America, 1 in 5 people will experience a mental illness that can benefit from treatment. And additionally, over the course of one's lifetime, about half of Americans will experience a mental illness. Now, the prevalence of most mental illnesses is relatively similar in rural and urban communities. However, the difference comes in who receives treatment. And in rural populations, people are significantly less likely to receive treatment and to have their mental illness be cared for. One unfortunate way that this manifests itself is through higher suicide rates. So this is a chart showing suicide rates in the US over the course of 15 years. And the blue solid line near the middle represents the national average. What's really stark about this graph is that as a county becomes increasingly rural, its suicide rate also very reliably increases. And in fact, in 2015, suicide rates were twice as high in rural communities as they were in urban areas. Additionally, what's notable is that the rate of increase is much faster in rural counties. So let's characterize a little bit further what this mental health care access gap looks like. Over 60% of rural Americans live in what's considered a mental health professional shortage area. This is a place where there are over 30,000 Americans per one psychiatrist. We just mentioned that about 20% of people experience mental illness every year. So you can imagine that one psychiatrist can in no way meet the needs of a town or area of 30,000 people. Additionally, 80% of rural counties have 0 psychiatrists. These do tend to be counties that have fewer people or less populated, but what that means is that people who do need care in these areas will have to travel much further just to seek and receive care. So speaking of mental health professional shortage areas, this is a map of the US showing which areas are considered HPSAs. And anything in blue basically is an HPSA, a health professional shortage area. The darker blue represents even greater shortage. The areas that are colored blue are definitely centered around or focused on rural communities, and California is definitely not immune from this problem. So this was an NPR article actually just exactly about this topic of the struggle of keeping psychiatrists or hiring psychiatrists in rural communities. One of the main problems is that only 1% of doctors in their final year of residency say that they want to live in a town of fewer than 10,000 people, and only 2% would be willing to live in a community of less than 25,000 people. So clearly there's this shortage of influx of doctors and psychiatrists in these areas. What's also notable is that the current psychiatric workforce in rural America tends to be older, and they are approaching retirement or actively retiring, and so this gap is continuing to expand. I also wanted to note that rural minority populations face very unique challenges in mental health care access. These include high rates of social isolation if they're apart from their family members in other countries, or if they're apart from people of the same cultural group as them. Also lack of health insurance, cultural stigma around seeking mental health care, as well as language barriers and lack of language concordance between patients and providers. This is a survey of California psychiatrists by race and ethnicity compared to the general California population. And I just want to note that about 30% of the psychiatrists who did answer this survey did not designate their own race or ethnicity. However, of the 70% who did, only 4% said that they were Latino, and that compares to 39% of the Californian population. Clearly there's a huge gap in Latino providers, and you can imagine that that would cause issues in terms of providing culturally relevant and culturally sensitive care, as well as language barriers when providing mental health treatment. So let's focus now on how we can close the rural mental health equity gap. What can we do about this issue? There are a number of opportunities that we can act upon and that are being acted upon in different ways in different states. One of these is incentive programs to incentivize physicians to practice in rural communities. These are things like loan forgiveness programs, grants, and higher salaries to persuade and attract physicians to these areas. This can be quite effective and it can attract physicians. However, one of the issues is that after a few years, physicians tend to move back to more urban places after they complete their contract and receive the benefits. Another opportunity is integrating mental health care providers and services into rural primary care clinics. This can be done by having a mental health provider or a psychiatrist who is based in a more urban area come to a rural community a few times a month, share a clinic with a primary care provider, and be able to see patients there. So this can be beneficial in terms of cost effectiveness and also reduce the stigma of patients having to sit in a mental health care provider's office. They would just be at their primary care provider's office instead. And then the third opportunity that I wanted to focus the most on is increasing access to telehealth services. And I think the reason that this is the one that really we can act the most upon is that UCLA has a very strong infrastructure for telemedical services. Especially with COVID, it's been expanding and growing, and I think this is something that we can discuss further. So telepsychiatry is the use of video and phone conferencing to provide psychiatric care from a distance. This can be with a psychiatrist, a psychologist, any mental health provider, a therapist, and it can be done either at the patient's home or it can be done at a primary care office where the patient would connect through the clinic's computer system. There are a number of benefits to direct care telepsychiatry. Some studies have shown that telepsychiatry can reduce wait times by up to 75%. So for example, this study, I believe it was in Ohio, showed that patients in rural areas were waiting 6 months to see a psychiatrist, and by expanding care through telepsychiatry, their wait was reduced down to 6 weeks. Additionally, it can improve patient convenience, reducing travel time and costs, and also reducing the amount of time that patients have to miss from work if they do have to travel to a faraway clinic. It has been shown to be quite high in patient satisfaction. Some studies have shown up to 84% of patients were satisfied with their telepsychiatry experience. And then also newly reimbursement through insurance is improving in telepsychiatry, and now, especially with COVID, it's become comparable to an in-person visit. And this is unfortunately a huge incentive for healthcare systems to integrate telepsychiatry into their networks. So I wanted to end this talk on a call to action. Specifically, we are at UCLA, like I said, a healthcare system that has a robust telepsychiatry infrastructure. And I think that UCLA Health and other urban institutions that have strong healthcare systems can not only use their care to improve convenience and to help patients who live locally in Los Angeles, but really working with rural clinics and expanding care to areas that need it most, where patients currently aren't being able to be seen. So I appreciate all of your time, and thank you for being here. Please feel free to reach out if you have any questions. Thank you.
Hello? All right. Thank you so much, Sahar, for providing awareness and visibility about the inaccessibility of mental health services among very much underserved communities in rural areas. Again, I want to mention that there will be a Q&A portion towards the end, so please make sure to stick around if you have any questions. And please make sure to add your questions in the chat box, or if you have seen our digital program, there is actually also a submission link where you can add your questions there. All right, I will now have the pleasure of introducing our last, but certainly not the least, presenter for today, Emiko Krantz. Emiko is a student in her third and final year of the UCLA Asian American Studies, Master of Arts, Community Health Sciences, MPH concurrent degree program, whose research focuses on racial health equity and community-centered health practices, especially as delivered by cultural community-based organizations. She serves as a graduate representative with the Asian American Studies Department, student representative on the CHS Equity, Diversity, and Inclusion Committee, volunteers with a number of Japanese American community-focused organizations, and enjoys spending time doing anything, usually eating, with her parents, grandpa, and the rest of her family and friends who have supported her every step of the way. Her fielding talk today is titled Beyond Gaman, Critical Factors Involved in Little Tokyo's Pandemic Response. Let's welcome Emiko Krantz.
All right, can you all hear me? You good? Thank you. Right, my name is Emiko. As the intro said, I'm in my 3rd year, and I'm going to be presenting on my thesis project for the Asian American Studies Master's Program, titled Beyond Gaman, Critical Factors Involved in Little Tokyo's Pandemic Response. And I'd like to begin this talk with words from my community. So Hiroko, 73 years old, a Little Tokyo Towers resident and recipient of meal delivery services, described, "Many of us residents are excitedly waiting as we hold our chopsticks. I'd like to express my deepest appreciation from the bottom of my heart." This quote comes from the Little Tokyo Service Center newsletter on the Little Tokyo Eats meal delivery program that started 2 weeks after Los Angeles issued its Safer at Home order on March 19th of 2020. A great deal of research on the Japanese American, or JA, community covers outcomes of the unjust incarceration of World War II, in which over 120,000 people of Japanese descent, 2/3 of whom were US citizens, were detained in concentration camps during the US's fit of wartime hysteria. This shared trauma has evolved into a shared history, discerning between those descended from the pre-1965 generation of Japanese migrants and those who migrated post-1965, a more recent community experiencing a different set of challenges in adjusting to a new life in the US. I seek to connect these experiences, far past and more recent, to the development of programs and services by Little Tokyo organizations in the COVID-19 pandemic. Of all the affordable housing residents living in Little Tokyo, like Hiroko, 90% speak English less than well, own no technology with internet access, and do not drive. Many of these residents are migrants who came to the US from Japan after 1965. They are part of the Shin Nikkei, the new generation of Japanese America, and rely on local services to provide resource navigation in Japanese, as most widely circulated resources in Los Angeles are limited to English and Spanish versions. Their understanding of healthcare systems is often rooted in the universal healthcare system of Japan, in which most serious health-related decisions are handled by the care provider rather than the family and/or the patient themselves. As such, navigating healthcare in the US, which is drastically different from Japan, is complicated, to say the least. Those of the pre-1965 generations who experienced the incarceration, also known as camp by people like my grandparents, face the challenge of surviving in facilities poorly equipped to ensure the health and well-being of incarcerates. Malnutrition, exposure to the elements, and disease outbreaks due to families being kept in close quarters are some of the commonly cited issues faced. Decades later, trauma induced by medical negligence in the camps led to formation of many JA-run organizations focused on providing culturally sensitive care for the needs of JA communities in the US. Both the pre- and post-1965 generations often cite this value of enduring the seemingly unbearable, or gaman, in their experiences. Gaman represents steadfastness, making the best of one's situation, with the undercurrent that the situation at hand is outside of one's control. While this may have been a value of the past, in light of the COVID-19 pandemic, Little Tokyo-based organizations' responses make clear gaman is not centered as a value of the present. Little Tokyo is situated in SPA 4, Metro LA, on unceded Tongva land. Geographically, it is home to residents of both affordable and market-rate housing, as well as businesses and organizations. Historically, many JAs in Southern California and across the US can trace some ties back to the area, lending to emotional attachments that inspire volunteerism and activism. A community previously challenged by the forced removal in World War II and now dealing with gentrification, exacerbated by the Metro Regional Connector, Little Tokyo then faced what hit the rest of the world in 2020, the COVID-19 pandemic. Businesses closed, events were canceled, key services were interrupted. However, the community did not simply endure. It organized, and here's how. The magic number for my research is 3. I focus on 3 programs and 3 services delivered by 3 Little Tokyo-based organizations. Little Tokyo Service Center, or LTSC, which provides social services and small business support in Little Tokyo and the broader Los Angeles area. Keiro, a nonprofit with the mission of enhancing the quality of senior life especially for aging JAs, and Little Tokyo Community Council, or LTCC, which organizes across a collective of Little Tokyo stakeholders to address unique needs and issues of the neighborhood. Through 12 interviews with staff and leadership, I seek understanding of the factors critical to creating programs and shifting services that provide for Little Tokyo, especially its vulnerable communities. For the purposes of this talk, I'll focus on programs and how they expanded accessibility to resources in the pandemic. In April of 2020, these three organizations came together to launch the Little Tokyo Eats program, or LT Eats, a hot meal delivery service that brought 18,930 meals to nearly 600 residents of affordable housing in Little Tokyo for over a year, addressing food access needs. We've talked a lot about food access before this, which laid down a lot of great context. Thank you to Dome for that. Similarly, in April of 2020, LTSC and LTCC banded together to create Community Feeding Community, or CFC. There's a lot of acronyms here, sorry. A meal pickup program that distributed over 10,400 meals to those whose jobs were impacted by the pandemic, free of charge. When I first heard of these programs, I thought, like, oh my gosh, how did they get full programs put together, funding and all, in like 2 weeks? LT Eats coordinator Mike noted a few key elements: a financial partnership with Cato, existing relationships with local restaurants, and landlord access to the affordable housing buildings. With Cato already assisting with funding various aspects of social services at LTSC, the two organizations were able to quickly come up with a plan to subsidize meals from local restaurants in communication with LTSC small business consultants for seniors who wanted to sign up. Additionally, because LTSC manages or coordinates with all affordable housing buildings in the neighborhood, accessing and navigating the buildings to deliver meals was very smooth. Deliveries were made by volunteers who contributed a collective 2,222 hours to the program. CFC thrived off a similar bond of trust between small businesses and organizers, with the additional financial aspect of demonstrated fundraising success. Over $195,000 was raised to fund free meals to those who came to participate in the program. LTCC Director Kristen noted how fundraising reflected community investment in Little Tokyo, even for those who neither live nor work directly in the neighborhood. Their emotional ties and feelings of community ownership motivated them to help in some way, such as through donations. The third program of focus is the series of vaccine clinics organized by LTSC. LTSC social workers noted that in the early days of vaccine distribution, the closest site to Little Tokyo was Dodger Stadium. Only 25% of housing residents had family members who could assist them with the vaccination process, leaving many against major barriers to vaccine access. Beyond that, I'm sure we can all remember how unpleasant it was trying to secure an appointment via MyTurn in those early months. So how were older adults with no internet access supposed to do it? Upon recognizing the need to bring vaccines to the community, LTSC began organizing its first of 6 vaccine clinics to distribute doses to residents in need, kicking off in February of 2021. Throughout the course of these 6 clinics, LTSC distributed over 500 doses to attendees. According to the County Public Health Department website, LA is currently about 88% vaccinated for residents over the age of 18. Comparatively, as you can see here in that more purple line, in late May of 2021, LA County was approaching 60%. At this same point in late May of 2021, Little Tokyo had already reached the 95% and over threshold for vaccination, the maximum indication by the LA County Public Health Vaccine Portal. When asked about how they did it, COVID-19 Programs Coordinator Ayumi explained how all levels of organizational leadership were involved. Board members sifted through their networks to identify hospitals and clinics to collaborate with. Social workers made phone calls in English, Spanish, Chinese, Korean, and Japanese to schedule appointments with their clients. And staff from various departments helped out the clinics with check-in and other tasks, such as walking residents back to their homes, which Ayumi noted was like a very cute, very LTSC aspect of hosting the clinics. These details allude to the key element of organizational infrastructure, such as having a well-connected board for securing partnerships and vast language capacity for providing services. Another key element Ayumi noted was trust. According to conversations with attendees, many felt safer attending an LTSC clinic due to familiarity with the staff, especially for those who were undocumented. In addition to having a large community space, the recently opened Budokan, a gym owned and operated by LTSC, all of these elements came together in a perfect harmony that Ayumi attributes to the success of these clinics. Synthesizing the takeaways from these 3 programs, as well as those of the services I did not have time to get into today, I identified 5 factors key to Little Tokyo's pandemic response: financial capacity, staff capacity, physical resources, and transcendent investment, which I define as speaking to both the financial and volunteering investment of those who live and work outside of Little Tokyo. That was 4 factors, and I've saved the most critical one for last, the one alluded to in all of my interviews, which is trust. Whether it be between or across, or within or across organizations, between social workers and their clients, trust is what ties all of these factors together. Cato could provide expedient financial support to LT Eats because of the existing trust with LTSC as partners. Trust in organizations and their staff played a role in residents' decisions to get vaccinated, and they had solace in knowing the clinic was operated in LTSC-owned physical space. Donors contributed to the CFC fundraiser because they trusted LTCC would use the money to directly support Little Tokyo businesses. Interviewees, those descended from the pre-1965 JA community, and Shin Nikkei alike, emphasized that when community members could not count on county services, Little Tokyo organizations filled those gaps. I connect these sentiments back to those histories of barriers in healthcare, those histories of injustice in camp. When we can't look to the government, Little Tokyo provides. The way I see it, no amount of cultural competence or not even cultural humility can hold a candle to the depth of historical, social, and needs-based understanding required to push successful programs forward like these 3 organizations did in the face of a pandemic. When the county distributed food boxes filled with traditional American pantry staples, organizations stepped in to make sure that boxes were supplemented with noodles, panko, and other Asian pantry staples. This case is but one of many to be made in advocating for the importance of partnerships between healthcare providers and local community-based organizations. Whether it's the city, county, or hospital systems like UCLA Health, teaming up with an organization like LTSC, that on-the-ground insight is critical to bridging gaps in access to resources, especially in a disaster like the COVID-19 pandemic. And that's because it is these community organizations who see a place like Little Tokyo as more than just another population to reach. It's our community, a place, a people, and a history in which we invest with gratitude for the past just as much as we do for the future. Kristen of LTCC brought up kansha, a sense of gratitude, what we do for each other. And I think that's what pushed us beyond simply enduring, beyond gaman. I began this talk with words from the community, and I'd like to end it with them too. From Nicole, a recent UCLA grad, LT Eats volunteer coordinator, and one of the many faces of the next generation of Little Tokyo leadership on the volunteer experience and its outcomes. And I think that it created like a lasting connection for them to the space of Little Tokyo as well. And hopefully it changed how they thought of it. I don't know, maybe like less of the commercial space and more like that people actually do live here. Yeah. And we need to be helping them and protecting the elderly residents, and you know, there's always an opportunity for you to help the community. Thank you. And here's my contact info.
So much, Iniko. And thank you so much to Jacqueline, Dome, and Sahar for a great series of talks today. And now we'd like to transition to the Q&A portion of our event. And so what we will do is we will ask folks in this room, as well as folks joining us on the live stream, to let us know what questions you have. To folks here, please raise your hand. We'll bring the mic over to you. And for those on the live stream, please feel free to use the chat on YouTube to send in your questions. All right, so we have a question here from one of our online attendees, and this would be for Sahar. So before we dive in, would our presenters feel comfortable coming up to the front so we can hear directly from you? Thank you. Perfect. Thank you. So the first question is for Sahar. What telemedicine services have you found to best support mental health? For example, video calls, app-based interventions, etc.
Thank you for the question. That's a really important one. I think one important aspect of psychiatric care that I didn't get to talk about much is the importance of that human interaction and providing that emotional support that unfortunately through telepsychiatry can be sometimes missing. That said, I think video telemedicine or telepsychiatric visits tend to be the most desirable whenever possible because you at least get that face-to-face interaction even if it's not in person. I actually saw a news video about rural mental health in California, and they were interviewing a woman who was very satisfied with her telepsychiatric care it connected her with a therapist who she really was able to benefit from. But she said that at the end of every visit, she would ask the clinic provider at the primary care clinic that she was taking that telepsychiatric call to give her a hug. So she would at least have a little bit of that in-person emotional contact as well. But video visits, I would say, seem to be the most desired.
Great, thank you so much, Sahar. We have another question, and this question is for Emiko. And Sharon says that she really enjoyed your presentation, great presentation. It's so heartwarming to hear how the community organized around each other. Were there other services / programming that came about during the pandemic?
Thank you. So I didn't get to the 3 services that I also focused on, which were social services, educational programs, and small business support, which are all facilitated by the same organizations that I talked about. My favorite example of a shift that they saw during the pandemic in delivering services is actually around ping pong. A lot of the social services providers were seeing that their clients had these drastic mood changes, either going up, having flaring tempers, or more depressive symptoms, as well as like a lot more bickering between residents. And so they were thinking like, okay, we have to get back to providing some programs as soon as everyone gets vaccinated. So once the Budokan opened, they had access to 9 table tennis tables and started to invite the residents to go play ping pong together. And apparently the residents loved it. Like they were going 3 times a week, rain or shine. And a lot of the social services coordinators were noting they saw how this return to community coming out of the pandemic was really making a difference for people's moods. So I think being able to identify the mood-based and also physical-based like observations that were affecting people's health, and realizing like, okay, we need to have some sort of physical activity, and also knowing that they had that physical space made like this huge difference. And now table tennis is a huge thing in Little Tokyo, so know that that's there. Thank you.
Great. Thank you so much, Emiko. So the one thing that really stood out to us and what made all of your presentations very powerful is that you grounded your talks in personal experience. And you highlighted clear calls to action that may seem grand, but are doable. And we have a question here about the research that you are doing and also related to the calls to action that you all highlighted. So for all the panelists, we have a question here. What has been your favorite or most memorable moment while doing the research that led you to develop these calls to action for your communities? Dom, would you like to go first? Okay, thank you.
So I think it's really important, for me at least, I think it's really important to be intentional about the work that we do, especially, for me, the reason why I'm in public health is my lived experiences and how I saw, the different social determinants of health and how that impacts health outcomes. And so, and especially, like I've mentioned earlier, food is such an important part of survival, and everyone, regardless of who you are, has a deep personal connection with food. And so I think the best part about, even though as we are just starting to think about the results, I think the best part of doing this research is the process. Along the way, I was able to learn more about the services that UCLA CPO offers. I was also able to learn more about, doing the graphs with Jacqueline the past few weeks. So I really pushed myself in my Excel skills, and really how do we highlight and center their voices, and then as well as how do we ensure that when conducting the future qualitative surveys, we also focus groups, we also highlight their stories and not just in public, not just claim it and recognize those problems, but actually do something about it. So yeah, so thank you.
So I think for me, with this specific research project that I discussed about today, it really came down to, for me, it felt like very novel approaches that I have not yet encountered in the literature of going down in the community and quantifying for this group how effective they could be in providing accessibility to resources relating to COVID-19 vaccines, and that there are endless possibilities to reach this population and other vulnerable populations that have many barriers to access to health. So I think that was the exciting aspect of this research that really kind of clicked for me, the endless possibilities, but also just the reminder that we're all human at the end of the day. And hearing from the personal experiences of those that are experiencing homelessness right now, and just bringing it back down to, I can relate to this person just like any other individual that I've encountered. And I think sometimes that may seem far-fetched from some of the research studies, and the humanity aspect sometimes may not be there, but I think that it was definitely centered in this research that I did.
Thank you. I think for me, I just have endless gratitude that all of these community organizations and the people at these organizations were so supportive through this whole process. And I wanted to make sure that while it is my research, I'm not centering myself and my own experiences in it. I wanted to make sure that this was adding something to or aligned with the goals and needs of these organizations. So being able to sit down before I even had those interviews with key players in all of these different organizations and hear about the ways in which some of my efforts could potentially help them, especially as so many of them were go, go, go throughout the pandemic. They didn't have time to document a lot of the work that they were doing. And so being able to develop these, what I called community-aligned goals for this research, to make sure that this is in no way me taking their time, but expanding capacity was a big motivational factor for me. So I think having that trust, which doesn't exist in all communities with academia, was really huge, and kind of inspired me to keep working hard too, because I knew that this was going to add to the community.
For me, as I explored kind of the psychiatric workforce across the country and looked into health access, I think there were two things that kept me grounded. One is that as a medical student, I am actively on clinical rotations, and I get to meet all sorts of people who have diverse experiences and really try to help them with their mental health issues in addition to their medical conditions. And I think hearing their stories and the struggles that they've had in seeking care, even if they are in Los Angeles, just knowing how much of a need there is for improved access to mental health care has really grounded me. I think second, there's been thankfully decreasing stigma around mental health and mental illness, and seeing kind of social media and the news cover more about these issues has really motivated me to keep doing this work.
Thank you all so much for those responses, and thank you to Maddie for that question. We have another question from a virtual attendee, but I want to see if folks in the room have any questions that they'd like to ask of our panelists. All right, that is also okay. And it might just indicate that y'all have given really complete responses, so thank you. Yes, okay, so Emiko has a question. Did you have a question? Perfect. I'll bring the mic to you.
Hello, I'm Dave Stokes, PhD student in the iSchool. So my question, you guys have consistently, a few of you, talked about entree and language barriers and being intermediaries for the projects. And I want to hear a bit more about that, gaining trust from some of the other, I don't want to call them interviewees, but some of the participants.
Yeah, so language barriers was a huge thing that came up for LTSC especially, and all of their social service support that they're providing, because as I had mentioned, a lot of the LA County materials were being distributed in English and Spanish, which is considerate of like the community makeup in LA that's predominant. But the big difficulties that came in here were especially for residents, but also for small businesses that had ownership that didn't speak English or Spanish fluently. There were big repercussions to if you didn't post things that were required by the county. So what came in here was this language capacity for social services to be able to translate and explain everything to those business owners, because you're already trying to stay open and you're doing your best, but if you don't understand those materials that are coming to you that you're supposed to post, then that's like a whole nother barrier there. I talked a little bit about vaccine access, and there was also the piece too that I didn't get to mention on how interpretation over phone was very difficult, whereas social workers used to be able to kind of help people through their medical appointments. Doing it over the phone is another sort of barrier, where telehealth was, as we've talked about, great to be able to make sure that service interruption was minimal, but there's still kind of that piece that was very difficult to work with. But luckily, all of these things were communicated with the organization because they had that trust in their social workers who they'd been clients of for a really long time. Sometimes they shared too much of their opinion on the way that things were functioning, according to a few of my interviewees. But because there was that communication there, they're able to make sure that there is a very robust response. And this kind of like leads into the question I had for Jacqueline actually too, on like the rapport building process for bringing in people from the community to help out. I was just curious about like what more went into that to develop that trust there.
Yeah, so that's something that I feel like is not talked about in academic experiences, that we talk about building rapport, gaining trust, but we don't really talk about the details, right? And something that I've noticed while working with the population that I did is that it was tricky, because coming in as a researcher, I have to still stay very professional with the community that I'm interacting with. But with peer ambassadors, actually, that allowed for them to have the flexibility to speak in the terms that they are used to in their community. And that was a game changer into how many people actually were getting vaccinated the day that we were, between me coming into the community and talking to them versus the peer ambassador. And I think, like you were saying, necessarily when you're doing this work, you don't have to be the lead in it. Your peer ambassador can be the one leading it, but you can be helping to guide for the outcomes that you're hoping for. In this case, it was vaccine access. And even with your peer ambassador, I think it comes down to mutual respect and an understanding that the commonality of whatever it is that your outcome is. In this case, it was vaccine access, and just making and establishing that that is the thing that you guys have in common. So pointing that out, I think, is essential.
Thank you so much. We have 2 more questions from our virtual attendees. The first question is for any panelist who wants to answer. Can you share a lesson with us, specifically a lesson you hope to bring into your work beyond the project that you discussed today? And it can be on the nature of doing research, on the nature of collaboration, on the nature of bringing in stakeholders.
So one thing that happened during the summertime is 4118, for those of us that are not familiar with that resolution, is that passed in LA County, and basically what that meant was that you couldn't be within 500 feet of specific entrances of schools, parks, etc. And basically it's essentially, in my terms, a vagrancy law, right? That if you are not meeting the stereotypical standards of what police officers or whoever's enforcing this resolution, that you could find yourself with a fine and jail time if you don't pay the fine. And unfortunately, that led to a lot of sweepings that were happening, but that impacted our work because we were then having to go out a month later, because not everybody wanted J&J, and then be like, where's our population that's here? Because they usually tend to stay in the places that you initially find them. But then the sweeping had an impact, and I think moving forward, I have started to have a found appreciation for legislation and policies, and really taking that into consideration, how that's going to impact my work with the population that I am trying to actively work with to provide them with resources. So that's something that definitely moving forward, I will always pay attention to.
So a lesson that I will take from this is, I think, so 2 things. First thing is, as much as, public health, like, we like to kind of discover the findings and understand the explanation to why things are happening, I think it's really important to have patience and respect, and as well as, with the people that you're collaborating with your fellow researchers and just the organizations, and ensuring that, you don't co-opt their experiences, and also you don't co-opt some of the things that they have done, and that you listen to them, you go through, you also work together to build this thing together. And as much as, it could be a lot of process of like back and forth and just like editing, the most important thing is that you don't, miss that, you don't go ahead and go forward without their consent and then without their support. I think another thing too is, Jacqueline has mentioned, I love for me, it's like something that I've learned is like the influence of, like working with communities and hearing people's voices, and then, in CHS, community health sciences, we learned about behavioral, individual level behavioral change and how we can do that. So that's important, but also so is policy. And so, so what's next, what I'm gonna do with this? And I think this, really inspired me to really think about what are the next changes, how we're going to, how can we do both, right? So listen to the people, but also influence the policy and ensuring that there are some stories that are embedded in these policies as they're being created and being advocated for, so that they actually meet the needs of the people that it's supposed to serve, or that these policies will be implemented in. Thank you.
Really quickly, I know we have another question coming up too, but I think this research also taught me to stay critical. There's so much to celebrate in the work done by these organizations. However, whether it be by staff capacity, funding capacity, there were limitations that I saw to a lot of these responses regarding support of vulnerable communities. I didn't touch on unhoused communities in this work, and was mostly focused on the communities of affordable housing, but I kind of saw in recent events too this limitation of empathy for certain vulnerable communities in Little Tokyo. When we say Little Tokyo community, everyone says, oh, that is very inclusive. However, actions recently taken by some of the small business owners reflect something a little different towards different communities which still exist in that space. So I think acknowledging that while there is a lot to celebrate, there's still a lot to be critical of, and that just shows that there's a lot more work to be done, and that there is a future too for the work that I'm starting now, which is exciting. But
yeah, I think that's a really great and deep question. I think there are a lot of lessons that can be learned. You all are doing more, I think, in-person research, whereas mine was a little bit more lit review and data. I'm doing database research in the background. So not, my research itself isn't personal, but the clinical care that I can provide in the hospitals is. And I think connecting the research to the personal experience is so valuable and really gives meaning to any research project. So I would highly recommend that if you are interested in doing a project, whether it's a service project or something of that nature, or research, then try to have some kind of personal component that you can relate it to.
Great. Thank you all so much for those responses. And this leads us to our final question, and based on your responses just now, I think it's a great question to end on. So we have a question from an online attendee, Calvin, who asks, specifically, what pushed you towards your current field, whether it be community health sciences or medicine?
For me specifically, I think it's a culmination of my whole existence, being very aware early on that, I was not allotted a lot of experiences that were meant for me to be where I am today, but yet I am still here, and I don't want other people to not live their best life. And I think Sir Michael Marmont, who's a public health like God and my academic crush, states it very well, that we should be striving for people to live their best versions of themselves, whatever that means. And I fully believe that, and that's why I'm in the work that I do, and I'm very passionate about what I do, and I advocate, and I do the research, because I think that we have to tackle the stuff that we're encountering and we're passionate about from different angles. So in a short sense, a culmination of my existence and my experiences, and hoping that I can then change the outcome for other people who are not allotted the same experiences that I am.
Thank you, Jacqueline. I think I agree with you. In that sense, that's the reason why I'm here. As I laid out, my passion for food access is rooted into my experiences growing up. And, I have unique experiences being an immigrant coming here at age 10 and being able to vividly remember my experiences there, my experiences here. And I think for me, in addition to what you said, I think, I think you and I came into, we started our MPH journey during the pandemic. And, while, as a student, oh my God, that was such a hassle, it was tough for us and all that stuff. I think about the problems that the pandemic has created or has exacerbated and what's next, right? So I think that it's really in our field, I left working to go back to school, and so now learning and hearing all these perspectives, I'm so excited to apply what I've learned and to have this newfound knowledge and really centering, okay, so what are the implications of the pandemic and how we can stop that. And so, yeah, thank you.
So beautifully too. Oh my gosh, I feel all the emotions.
Yeah, I'll start this out with just recognizing, I come from a very privileged background where I've had so much support my whole life, and whether that be through my family or also through my community, that I'm supported academically and have a lot of opportunities. I think that that kind of pushes us to really reflect on, like I talked about earlier, Kansha, and the sense of gratitude and paying things forward. The importance of taking everything that we have and acknowledging where a lot of that comes from in order to align your motivations and make sure that you're paying back to the community that uplifted you, but also paying it forward to the future of it. A lot of these services in Little Tokyo have been around for decades, and that's because so many people have put in their work. And recognizing that and seeing that there's this space where I can also contribute as I go through my academic career is what brought me to really marry together Asian American studies and public health. I have this background in ethnic studies and being able to recognize on like this sort of historical level where a lot of these attitudes and behaviors are coming from, and that better informs the ways in which I go into my research and maybe also the future of different programs and services in that community space so that I can better understand these needs and how to work with that in the future. This can also help frame, like, maybe as I move on, working with different communities that aren't my own, this understanding that, like, this is what's important to me in my own space, and I need to be able to respect that in other people's spaces. And so I think just all of this gratitude that I have in my body that is leaking out is really what drives me forward and has brought me to see the value of being in public health and ethnic studies spaces.
That was beautiful. So I agree with you all. I think, especially what Jacqueline said at the beginning of wanting to help people live their best self, the best version of themselves. And I just really wanted to maximize people's quality of life to the best of my ability. And I felt like as a physician, I would be able to do that. I also am very interested in the intersection between medicine and public health. And I think that by working together, we can really help improve the healthcare system and make it more equitable moving forward.
Great. Thank you all so much, Jacqueline, Dome, Emiko, Sahar. We are very appreciative of the time and the content of your presentations today. I think even now, the responses that you all provided, it's really reflective of the depth of your experiences and the extent of your passion for the work that you do, and it's truly inspiring, so thank you all. That concludes our Q&A portion. Thank you to everyone who submitted their questions. So we're going to go ahead and transition to the closing remarks from our advisor, Julian. Thank you all.
Yes, thank you so much. My heart is full, my cup is overflowing, so thank you so much for inspiring us all here and online. So I just want to share that I've learned so much from the presentations. To the attendees online as well as in person, you could clearly hear and see the heart and passion the students have for their communities. From COVID awareness and prevention to mental health and food security, they show that caring for each other can come in multiple forms, and one does not have to travel far to make an impact in the world. Thanks to Jacqueline, we've learned about outreach efforts through peer ambassadors, as well as the need for future research to promote vaccine access among those that face housing insecurity. Thanks to Dome, we learned about how food insecurity is interconnected to social and physical factors of everyday life, and how that has further been impacted by the pandemic. Thanks to Sahar, we learned about strategies such as telehealth to help with the growing mental health crisis, particularly due to the shortage of psychiatrists and counselors in rural areas. And thanks to Emiko, we learned about Gamang and Kansha, and that there are always an opportunity to help our communities, especially in times of need. And in those moments, we feel a deeper connection to our communities. Closing health equity gaps and increasing access can begin where you're at, and we don't have to wait to be tapped on the shoulder to be called to do the right thing. After hearing the students speak, I think of a really relevant quote from one of my favorite authors and orators, Maya Angelou. She once said, "Just do right. Right may not be expedient, it may not be profitable, but it will satisfy your soul. It brings you the kind of protection that bodyguards can't give you. So try to live your life in a way that you will not regret years of useless virtue and inertia and timidity. Take up the battle. Take it up. It's yours. This is your life. This is your world." These students are living examples of doing right now, where they are. And I feel they embody the theme of FieldingTalks and of National Public Health Week so beautifully. Thank you again to our speakers, to the organizers, our partners and our sponsors, and of course to you all attending today, either in person or virtually. And please feel free to connect with each other in the time that we have. Thank you all again, and have a great Friday.